Our next speaker is Professor Ramesh Jain, Professor Emeritus from UC Irvine, and he will be talking about personalized health, the next frontier in healthcare.
Good morning, everybody. First, thanks to Ramesh and CalIT2 for giving me a chance to visit this campus after some time. I was really pleased to be here, and I was very surprised how much it has grown and how fast it has grown. When I thought I knew this part of the campus, driving here, it was completely different experience. But that also reminded me that famous saying that some people improve a place by joining there, and some people improve a place by leaving that place. So I belong to the second category. I will be sharing with you thoughts on a topic, once again, that was put on as a topic. I will be speaking by Ramesh Rao himself. So the topic is personalized health, the next frontier in healthcare. I'm now afraid because we heard two healthcare professionals giving excellent talks. The thing that I liked in both talks, the first talk started on the first slide. It said, every older person is different. My wife will translate it to, because she always keeps on saying, why are you so crazy? Now I will repeat that's everybody is different, so you are considering me crazy, used that different term. In fact, that talk was very interesting to me because that talk and the second talk on addiction, both those things came from perspective of health side or healthcare people. I did not know ABC in biology till about 10 years ago or 15 years ago. When first time I started thinking about health, I had absolutely no idea what to expect. And I started learning as fast as I could because I wanted to do something in this. Maybe I recognize that I'm getting older. So I have to take care of some of the things. And my basic background is engineering, computer science. So now you will hear some perspective coming from computer science side. Okay? So the first thing I want to start by saying is, what is personalizing health means? If you have heard P4 health or P7 health or P11 health, we are going to focus only very few Ps. The fact is, because of all the advances that are taking place in almost all the areas related to health and related to computer science, this is very exciting time to explore some of these things. There is a famous saying that do you want to add life to years or you want to add years to life? Atul Gawande wrote a book on mortality and morbidity by arguing that most people currently start worrying about measuring how long people live, and they start giving credit to healthcare for living longer. Okay? And coming from Atul Gawande, this was a very important statement because he argued that we should be thinking about the quality of life a lot more than length of life. Okay? So the thing is, very interesting thing is, can we add both life and years? Okay? And I think time has come that that's quite possible. So the first thing is, when we talk about person, and it was very nicely explained in the first talk, that person ultimately is combination of multiple factors. In the second talk also we started seeing that what kind of lifestyle starts affecting, and those are the serious effects that take place and they continue. So when we start looking at those things, effectively each person is nothing but a combination of these three things: omics, lifestyle, and exposome. And when you start considering that these three are the factors, you have to combine those factors, and based on that, you have to say, how is every person different? Not just older person, but every individual, even a 5-day-old child, is different than anything else. And they are just growing differently because of the model. But then, most of the experiments that we run are population-oriented experiments. All the treatment that we talk are population-oriented. How can we really start understanding a person without longitudinal data related to their lifestyle and related to the exposome? And that's what becomes a very important thing, particularly in chronic diseases and mental health. It doesn't affect some other things, but as we all know, these two dominate: the expenses, quality of life, and length of life. Okay? So how do we take care of some of these things? So we can start collecting longitudinal data and start doing some of these things there. The next thing is, some of the people started talking 10 years ago from Stanford, Ronald somebody, Alzheimer. So I don't remember his last name right now, but he started using the term sick care. And he started arguing that we don't care for health, we care for sickness. And when you start thinking about this, I'm just going through this in the last 1 month, that I had this beautiful dog. Something was going on with him, but we did not worry about it till we saw him in the second position. And then suddenly we found out that he is having serious lymphoma and all these things, and we may even have to make some very hard decisions literally tomorrow. Now, when we start thinking about this, you start thinking, how does the healthcare really work? And you start seeing that healthcare is no different than fixing any other appliances. Your computer, your car, your home, or your health. In every case, what happens is very simply that you go to a person who is trying to fix your problem. They ask you for all kind of things. When did this happen? What did this happen? Etc. They collect as much data. They also try to get you to perform some more tests. And using all those tests, then they start thinking what is going on. And based on that, they start coming up with prescription. Being a computer scientist, to me, the first problem is the data collection problem. The second problem is state estimation problem. And the third problem is recommendation engine problem. This is what is going on. So how can we start implementing some of these things? What the big problem with the current healthcare is that, unlike all other repair problems, in most other repair problems, you get the estimates and you get guarantee. Can you expect that in healthcare? Good luck. So, one of the important things that we need to consider is that our health is not an episode. It is really a journey. When you go to visit a doctor and you spend half an hour, if you are lucky, with a doctor in a year, the remaining time, just think, your health is still continuing. Your life is going on. But nobody is doing anything there. The second thing is, our health is a state. It's a dynamic system. It's continuously evolving. Okay? And it is very strong self-correcting mode. What does self-correcting mode mean? We all, particularly those who are coming from health side, we know that homeostasis is nature's most powerful engineering mechanism, particularly with respect to health. All the organs, all the systems that are working in your body are working in health, homeostasis mode. When you start looking at homeostasis seriously, all that you find is that this is nothing but a simple feedback control system. In fact, cybernetics, the term coined by Norbert Wiener, was inspired by homeostasis. Yeah. And that's why the title of his book was Communication and Control in Man and Machines. Yeah. So he started considering those things there. So the important thing that we have to start considering is, and that's why I liked in the second talk that emphasis on longitudinal studies or longitudinal data collection, that we have to start focusing on continuous measurement and self-correction. These things are basically what we call cybernetics. So, a general question to you. I'm sure most of you have been to a doctor, or your friends and family have been to doctors. When do people get best health care?
Right before they die. Right before they die.
Right before they die. And that's a fact. Yeah. So, when you start thinking about this, that you get full attention at that time, etc., you start thinking, how can we provide best health care to people? If you are a crazy person coming from computers or all this kind of areas, then you start thinking, why don't we put people in ICU from the moment that they are born? And we keep them in ICU all their life. Yeah. When I mentioned this to a friend of mine, Howard Fedorov, who was at one time Vice Chancellor of Health at UCI, we were discussing about something. So I said, why don't we do that? He said, Ramesh, that's too late. We have to start considering what happens when the child is, or when the child is in the mother's womb. So we have to start considering that thing there. But in the simplistic term, what will happen if we can put a person in ICU right from the time and provide them virtual guidance all their life? And this is possible. This is what is really happening. Many of you are wearing rings, many of you are wearing watches, all of you are carrying smartphones. Yeah. They are collecting all your lifestyle data, they are collecting all your exposome data. Okay? And they are collecting more sensory data than they collect in ICU. And if the data is available, which is now available, there are more doctors, more healthcare providers. They can analyze the data, they can observe the data, they can apply all the tools and technologies to help people. Yeah. So why not we do that? And then we start thinking about how do we fix sick healthcare? How do we take away some of the things that healthcare is suffering from? Oscar Wilde famously argued that society exists only as a mental concept. In the real world, they are only individuals. What are the implications for us? Implication is very simple and very direct. Population is an aggregate of people. People are not a sample of population. If I go to a doctor and they try to put me as a 70-plus-year-old person, or an Indian person, or a person living in California, or a person who is alcoholic or non-alcoholic or all this kind of thing. They are trying to put me in a particular group. The thing is, I belong to lots and lots of groups. Yeah? And this is a very simple concept. How do we start using this? That in place of experimenting with population, experiment with people. And that's what some of the scientists in healthcare or health field now have started talking about N of 1 experiments. So N of 1 phenomena should be the primary phenomena, not the population-based phenomena. Because you can always create correct population based on N of 1 data, if that's available to you. Okay? So what are the other implications of this? Right now, we have very little empowerment. What we want to do is to empower individuals to take action. In the background, the scene that you see is the Shibuya crossing in Tokyo. The most difficult crossing you can consider. There are thousands of people crossing every time the signal senses. Yeah. But everybody knows what the rules are, what kind of things have to happen. Everybody is taking individual decisions. They are empowered by providing them correct knowledge and all the things. So the important thing is, how do we start empowering people? Okay. What we need to do is really these three things. We have to provide people the correct knowledge that we can provide to them about health information. One of the things that you find most difficult is, even for what should I eat, that was referred to in terms of habit formation and these things. If you talk to most of the people who are working in the research in that area, they will tell you that 90% of the information that most people know about food is wrong, is disinformation. Yeah. Because of the marketing, because of the government control, because of the religious practices and all this kind of thing, the nutrition health aspect goes down the drain. Yeah. The second problem that comes in terms of the healthy eating is, if you take a person who grew up in India like me and start telling him that I should be eating only spinach and broccoli in salad, how long do you think I will survive? Not Ramesh Rao, he can do that all the time. Okay. But if you tell that to me, I will survive 1 day or 2 days. After that, I need entirely different kind of food. So we cannot consider food only from nutrition or health perspective. We have to consider both aspects. Remember adding life to year and adding years to life? It's exactly the same problem. Okay? So how do we do that? The second thing is personal health navigator. We all know about health, about map-based navigation system. Can we develop that for health? As easy, all the time, remaining with you and telling you, this is good, that you should not be stressed, that you should sleep well, you should do exercise, and all this kind of thing. But how do I know what to do? Am I doing too much or too little, and these kind of things? And finally, when disease is there, how do I manage that? So all these three aspects, here comes a computer scientist in me and an AI researcher. All my life I have worked in cybernetics and AI. So based on all the things that are happening currently, these are the three things: conversational multimodal systems, health agents, and foundational models that you can start applying to start building some of the tools to do exactly the type of things that you were hearing in the first two talks. Okay? So how do we do this? You all hear about LLM-based systems, and you all hear about hallucinations and wrong information and this kind of things. Everybody emphasizes that we got to come up with very solid evaluation things. Okay. Uh, Evaluation is of two kinds. Number one, as you see, the first is accuracy, but the second things, particularly in healthcare, that are important are trustworthiness and empathy. These things have been emphasized quite a lot, and that's where a group of people from many places in this country and outside got together, and we worked on what we started calling foundation metrics for health related applications. We came up with how do we start evaluating those things, and how do we measure that people will really find it trustworthy and things like that. So that work is now being applied to mental health and things like that. I will not get into details about that kind of thing. But the second thing is conversational health agents. We are all getting used to bots. Okay. Now we start talking about conversational health agents. OpenAI talks about these 5 levels of creating AI. At third level, they start talking about agents that will be able to talk and that will be able to do some powerful actions. Let's look at that in terms of the health aspects. The type of information that you require in order to help a person, remember we talked about navigation and these things which we'll talk in a minute a little bit more, is the important thing is how do I converse with the system? And in order to do this, my health agent should know about me, should know about my background, should know about my language, should know all kind of things. Also, it should have the latest health information. So based on this, we developed a system which we started calling conversational health agents, or CHA, C-H-A. Lots of people showed interest in this. We now have something called OpenCHA that's being made available to lots of people, and there are hackathons in Bay Area that are going to take place around this so that you can develop different applications based on this. The important thing about this is, I will not go in details about this diagram, but this diagram, let's divide into 2 parts. Bottom part and the top part. Bottom part is purely based on LLM type things, but the top part has information about you, about different processing systems, about healthcare related things. You do not want to share those things with the LLMs. So how do we start bringing in those things there? And that's what this system is trying to do, so that your personal information is not shared with the LLM. Similarly, different healthcare people could be developing their own models that they will not be shared with the LLM and things there. They can be used for their own applications. I will skip this slide in the interest of time and come to this. So how do we develop this personal health navigation, which is as easy to use as map applications are? Okay. In order to do this, all that we need to do is the following kind of things. First, a very simple thing. What makes us healthy according to World Health Organization are these numbers. Okay. Look at this number. This is where we spend our money. We spend 88% of healthcare related expenses on medicine, which affects only about 10% of our health. Okay. Something has to change, and that's where you find out that these things are really lifestyle and related aspects. Most dominant is food. So should we start doing this? Can we start taking this healthcare model that we discussed earlier, modify this, make it a closed loop system that follows cybernetics? It brings in the personal model, uses that to attain a particular goal, and keeps on self-correcting all the time, using your lifestyle factors, and of course, sometimes when medicine is required, it uses that. Okay? So can we implement this thing there? This is a detailed diagram of how it happens. On the left-hand side, you are collecting all the data. On the green color, you are collecting and building the model, as I mentioned to you in the beginning, based on omics and your lifestyle-based things and environmental factors. Then there is estimation stage. You are always collecting it, comparing it with the goal, and so on. So effectively, when you start looking at this, looking at the goal and then going forward with all possible data, and different knowledge sources can feed into this. Okay? So you start putting a system like this into action. There are healthcare providers in the loop. They are looking at this. Remember, we talked about ICO. So we are effectively putting the thing in ICO. So when we start considering this, interestingly enough, this architecture or this thing had been adopted by International Standards Organization and HL7, and they are standardizing this architecture so that people can start adopting and building around this architecture different things. And when they started doing this, they took that architecture that I mentioned to you and they have modified it. In place of 3 things on the top, they have put the 4 things there, and they are starting to put those things there. Okay? This is what they are trying to do. In summary, what we are trying to do is, if we want to develop personalized health care, then the first thing is, how do we unify health insights from different sources, from different knowledge things? How do we provide this at the right time to people, at the right place, in the right situation, in the actionable form? Okay? And how do we make it so that people can trust it and they are sure about what they are going to do and so on? Thank you very much.
Questions for Ramesh? Laura, you want to come down? There's a microphone over there.
Hi, thank you for your presentation. I had a question just about like the lifestyles, the money being spent and the time being spent.
Can you speak closer to microphone, please?
Yeah.
Yeah.
So you mentioned that 88% is we spend on medicine instead of lifestyle changes. I know that every time I go to the doctor and I get 15 minutes or so, they like to emphasize like exercise, take walks, 30 minutes a day, drink water, eat this and that. And it kind of relies a lot on the patient's accountability to take that light advice and put it into practice. Would you say that to kind of increase accountability and trust in AI to help monitor or just get data from the patient, that there can be tools developed where the doctor can promote it and normalize it to patients to help improve that accountability?
In fact, that's a very correct observation and point that you are making, that it is good to get the correct advice, but how do you practice it? Because even for the medication, there is data that more than 50% people never follow that. And when it comes to exercise, sleep, and food, the percentage goes down significantly of how many people can follow that. And it's not that they don't want to follow it, it is that it's very difficult to follow it. And by building it into this kind of framework where you will be feeding in that advice also, because if you go back to the architecture, in this architecture, that orange part is coming advice from them. And that advice becomes part of the system that you are supposed to be doing this. And because you are continuously monitoring, the system is monitoring whether you are following the exercise, eating the right things or not, and things like that. So that will become part of that.
Okay. Thank you so much.
Thank you for the topic. I fully agree on broccoli, though, my kids born here, they like broccoli. I have not been able to make that transition. I think these are, again, really great way to reimagine how healthcare is delivered. do you think the well care system that we are hoping that I think is going to come about, do you think that can or should exist separate from our sick care system that we have today?
In fact, wellness or well care system that you are going is a step in right direction. But what I find is that it is an incremental step. Yeah. What is happening is that when you will go every year, or you can increase it to every 6 months, they will be measuring some of the things and they will be giving you advice. As far as I know, you are a doctor.
Yeah,
To Ramesh Rao, he was taught by Shannon that there is a sampling theory, that if you have a signal and you want to understand what's happening with this person, there has to be a minimal rate at which you will sample it. If you don't sample it, then you really don't understand what's going on in the sample. Yeah. So this sampling rate of once a year or twice a year is very poor.
Right.
It's a good step, but we have to go much more. We have to go towards continuous measurement, and from there we can start doing things there.
Right. I think a lot of, I think the lack of personalization that you see, a lot of it is kind of built in the reimbursement models and which have created our health system, right? So if you are giving to a PCP only 10 to 12 minutes really, which is on average, and they spend maybe 5 of those with you, right? There is no way for them to do great care, right? So I think maybe it has to exist outside of healthcare. So once people see the money is flowing differently, behaviors will change.
So you made a very interesting point. I cannot resist that. When I started talking about some of these things, one of the things that I was asked many times, and my response used to be that unfortunately the current healthcare system, and these are not my words, I was very much inspired by Eric Topol, who is right next door here. When he wrote his book, that became my most important reading in medical side, that creative destruction of medicine. And the problem with our current healthcare is there is insurance, there are healthcare providers, there are employers. All these three systems work together. Every election is based on healthcare. But these three systems are working. Where are people?
Right.
Where are we empowering them?
Right.
Where are we taking care of them?
We want to sneak in one last
Thank you.
No, that was just related to what you were already talking about on incentivizations, monetary incentivizations for this, right? Because if the current systems are incentivizing, reactions versus being proactive, how can we, or do we need to shift the incentivization structure of insurances, of healthcare providers, of private practices of these people to also, on the other side, encourage the sort of framework of like cybernetics and homeostasis and personalized medicine?
And before you answer, could you introduce yourself?
I'm Armand Johal. I recently graduated from UCSD. I work as an AI engineer for a healthcare startup.
Very, very interesting question. I have been struggling with the right answer for this for at least 8-9 years now. So much so that on a personal note, I decided to quit my regular job 4 or 5 years ago, and I'm emeritus, so that I can go and do whatever I want to do, wherever I want to do. And the reason is I very strongly started seeing that this kind of thing cannot start very easily in countries like our country, here in the US. The reason being, whenever you try to build a startup company or write a research grant or anything, one of the questions finally comes down to the fact that who is going to pay for it? Yeah. The aspect that whose health is going to be improved, how much it's going to be improved, is secondary or tertiary. The first thing is who is going to pay for it. Until we break that, we cannot do it. So should we go to countries where the healthcare system is not so strong? Arguably, we have the best healthcare or most advanced healthcare in this country, but possibly the worst healthcare system in the world.
Thank you, Ramesh. I hope you have plans for